started your timer and here is your question. Right, so if you have read and understood, considering it communication skills question, kindly begin.
Hi. Sorry. Just before starting the recording, I just want to ask a quick question and then I will start. So,
thank you. Okay, started. Yes, continue.
Hello. This is Dr. Shoaib, one of the surgical trainee doctor in the ward. Am I speaking to Mr. Mann?
Yes, you're speaking to Mr. Mann.
Hi, Mr. Mann. So I'm calling you from your ward, basically because I'm worried about a patient, one of your patient, who has, who seems to be in Oliguria, having a background of his post-op day 1 of elective right hemicolectomy for the cecal tumor. So, and the post-operatively, the patient is tachycardic, hypotensive, and the UNEs are both raised. And during the operation, there was drop in HB and he received bloods. She received 2 units of blood as well. But now on examination, the abdomen is soft, non-tender, ECG and chest X-ray are normal. And my assessment is patient is dehydrated, and I just want to discuss with you for further plan, if that's okay.
Okay, doctor. So who's the consultant managing this patient?
So at the moment, the consultant on call is someone else, but it's your patient.
Okay. So what do you think is the cause of the patient's oliguria?
I think the patient, intraoperatively patient was bleeding and received 2 units of blood. But post-operatively, we have given just 1100 mils of saline, which is, I think, less for this patient, and patient is dehydrated. So my assessment is patient is dehydrated, and I'm planning to give fluid bolus, and then I might repeat the fluid bolus and continue aggressive monitoring, and will let you know the further progress.
Okay, doctor. Aside from the fluid bolus you're going to give this patient, what else would you want to do for the patient?
So obviously, I will number one, resuscitation. With resuscitation, I will do some bloods at the moment. I will check the full blood count and UNEs, the fresh UNEs. I will repeat them, and then I will start 1 hourly monitoring rather than, or maybe less than 1 hour monitoring, and I will update you regarding the fluid bolus. Response of the fluid bolus, and then.
Okay, that's
obviously,
okay.
it's a first post-op day,
so
but still I will send some blood cultures as well. Sorry?
Okay, if it doesn't improve after your fluid bolus, and there's no response to your overnight challenge, what else will you do for him?
Well, I would be then in that case, I would be thinking that the patient might be bleeding inside, And that's why I just want you to be aware for every situation.
Okay.
So, yeah.
Okay. Okay. Do you think this patient would benefit from high dependency unit care? And what do you do? What do you think can be done?
Well, at the moment, I have started resuscitation, and I will see. I will monitor closely, and if the patient didn't improve, then I will obviously update you as well, and I will talk to the ITU team. And if the patient starts deteriorating, then I have to shift him, and I have to talk to them after your consultation.
That's okay. So, do you think the patient is bleeding? Can you hear me?
Sorry. Yes.
Do you think the patient is bleeding?
Well, I can't say at the moment. I'm not sure. It might be, but apparently it looks like patient is dehydrated. So if after resuscitation and monitoring, I will be able to give you more knowledge about that and more assessment on the basis of my resuscitation and monitoring.
Okay. So, do you think it's an anastomotic leak?
Well, it's day one, so it's too early to say something, but then again, I'm not sure, and it could be, but it is very less likely.
Okay. All right.
Yeah.
So what would you do?
For that, I will obviously.
Yes.
Sorry.
What will you do? What will you do to watch out for an anastomotic leak?
So, sorry.
What will you do for the patient to rule out anastomotic leak?
For that, I will go initially for the ultrasound, and before that, on examination, I will keep on monitoring the patient's abdominal girth, and I will also monitor the patient's abdominal distension, and I will see if the rest of the signs are matching with this, and plus radiologically, if I have suspicion, I will go for ultrasound first, and then I might need CT as well.
Fine, doctor. That's fine, doctor.
Yeah.
Do you need me to come to the hospital now?
Well, not at the moment. I wouldn't say. I would say, but I will keep you updated. And if there is anything which I need help, and if I need any urgent, I think if I need it, I will let you know.
Okay.
After my resuscitation. Yeah.
Okay, doctor. That's fine. So I think you can go ahead and continue the resuscitation. If you need any assistance, you can always call me.
Yeah, thank you very much. So anything specific you want me to do in that case?
I think that's fine. That's okay. You can just go ahead and continue the resuscitation.
Yes. Does the patient needs to be transferred to HDO?
Sorry?
Does the patient needs to be transferred to HDO?
Well,
high dependency unit.
Yeah. So basically, at the moment, I have seen the patient. I have started resuscitation. I will see how the patient will respond to resuscitation, and then I can say something. If the patient is simply dehydrated because the patient received only 1100 ml saline, so then if the patient is responding to fluid challenge, then she doesn't need to be shifted to HDU. But if despite my repeating the boluses and patient is not improving, and the other vital parameters, including respiratory rate, heart rate, is increasing, and hypertension is worsening, and urine output is also poor, so then I might need to shift to the.
Do you think patient needs to be operated right away?
At the moment, I'm not. I don't think so, but that's why I'm discussing. If there is, if you think differently, then obviously we can. But for my at the moment, my assessment is we should start resuscitation and monitoring, and then we see how the patient will respond to the resuscitation monitoring, and then we can decide. For the moment, I don't think so. Patient needs something.
Okay. Can you
urgent.
please tell me what might be the cause of shock in this patient?
In this patient, the one of the causes we have given less fluid, so dehydration, and other could be the patient might be bleeding. So these are the two possible, and the third one could be patient is going into sepsis.
And patient is a post-op case, so there could be secondary acute kidney injury.
Yeah, it could be atelectasis.
Yes, okay, and acute kidney injury.
Pulmonary atelectasis as well.
Okay.
Yeah.
Did you check if patient's catheter was not blocked?
I should have checked, but in theory, I think they have already written that in notes that the catheter is
Not
like in the scenario they will give it.
Would a patient present if there was a catheter blocked, or how would the output be if the catheter was blocked, or if there is oliguria? Very simple question. How would you know? By just looking at
the other parameters wouldn't be same. If it's just urine output would be decreased, like there won't be massive tachycardia or like hypertension. So these are the other parameters, plus patients peripherally, the CRT of the patient, capillary refill would be normal, and then patient won't be pale, and these are the other things. And the urine output, the urine color would be obviously, if I will see the bag, if there is a normal urine color, or if it's concentrated dark colored urine. So if it's normal, then I could think of there is a blockage. But if there is a very dark
blockage and kinking, then there'll be zero output, most likely.
Will be,
but if it is 10 or 20, so that
right
means,
from the beginning.
Right. So then you don't have to mention all these 100 reasons. You'll just look. If it's kinking or it's blocked, there'll be zero output 1 hour after second hour. So if it's zero, then you know. And if it's this little amount in 1 hour, and then again 10 ml or 20 ml, then there is oliguria, then that is not, that's the problem. Okay, good. Can Dr. Abbas, can you give the feedback first, please? How he's busy, I think he's got something. Anyone else want to give feedback? Yes, please. Dr. Abdulaziz.
Sorry, ma'am.
Yes, please. Can you give can you please give the feedback?
Yes, ma'am. I think my advice for Dr. Shoaib is I think he should go through Brazil notes.
Yeah.
He has the knowledge. Yes, very well. However, I think he needs to organize it. So he should go through Brazil notes. There is and then what Madam was trying to ask him about the sequence of management of oliguria. I think he was I presented this last week, and it was Dr. It wasn't Dr. Snehal, I can't remember her name, who guided me about how to explain how to discuss this case. So I think the best thing is to first start by telling the consultant, when he asks you, what will you do for this patient? First thing is to explain to the patient, okay, no, sorry, what's wrong with this patient? I think the patient is dehydrated and he has oliguria. However, it's possible that the catheter is blocked. So I'll ensure and check that the catheter is not blocked. I'll do an abdominal examination to rule out urinary retention and check for blocking of the catheter. The patient may have some anxiety, so I'll tell the patient to be a bit patient and then attempt to pass urine. If the catheter is blocked, I would want to change the catheter. So then, before you now talk about doing your fluid challenge. So if you follow it that way, it will be easier for you to remember. Then the other question was about if overnight, after your overnight fluid challenge, the patient does not respond, what will you do? Yes. So you should have talked about, okay, yes, I had to prompt you to tell you, okay, you have to send the patient to the HDU. It's important to remember that the patient will go to the HDU, and then you may need a nephrology consult for the patient.
Yeah.
Then, so when you send the patient to HDU, what do you want to go and do then? You would insert a central venous catheter, and then you would want to monitor, administer your fluid, and then monitor your fluid administration. Because the reason why you want to put a central venous catheter is to ensure that you don't overload the patient with fluids. and to ensure that the patient is getting, and we want to monitor the central venous pressure assessment. So we press the central venous catheter and then monitor the patient, and then continue a quick challenge and monitor the patient's response to fluid administration. So basically, that's just a few additions I wanted to add.
Yeah. And then one question will be asked: if there is no bed available in HDU, what would you do?
Okay, Ms. Marine, sorry, I will answer this. Let me answer this question first, and then I have to ask the HDU thing again. So if there is, there won't be any bed. So I will obviously ask the nurses of my ward to do the monitoring, because there are beds which are like having monitors and more aggressive monitoring devices. So I will put the patient over there, and then I will ask the registrar if there is any potential patient who is gonna move somewhere else, so that let me know as soon as the patient will leave. And then I will talk to the bed manager, as well as I will talk to my consultant and tell them that this is the situation. Ask the bed manager to do something to, if any patient could be moved from the HDU somewhere else, and obviously the ICU team as well.
Okay.
Yeah, and still, if we couldn't, and we think the patient really needs urgent shifting, and there we couldn't find anything, and then we can talk to like any nearby hospital if patient is in a situation to be transported to other like any nearby facility. So these are a few different steps which we can take.
I have little objection with the first one that you said you'll talk to the nurses, because this is your patient, your responsibility. As long as the bed is not arranged, you should be taking the responsibility of the patient yourself. This is what they want to hear. And then you said you'll talk to the bed manager, etc. Okay, those are acceptable, because you'll talk it out. You'll talk to the bed manager. You'll talk with your own consultant. You'll find a way out. But as long as there is no way out, you are going to take the responsibility yourself.
Sorry. So that's what my when I said that I will ask nurses of my ward, that means I will actually take care of the patient myself more aggressively until I find that's what I wanted to say.
Yes, but then choice of words is very important. No one will ask you to explain what you have already said. So once you are saying something, use the time wisely and use the words very intelligently, so that you wouldn't have to sit back and explain, or in your mind you're explaining, oh, I wanted to say this, because time is your enemy. You will not get that much time for explanations and etc. Actually, people, when they appear in the exam, they find it really shocking, because what they were expecting, how it would be, their consultant is not cooperating. They'll not give you that much time. They'll not even, because this one will be on over the phone. So you won't be able to see the expressions. You won't even be able to know who the person behind the mobile wires was, who was the consultant. So you won't be able to. So I don't know if he would be able to convey that you would be able to explain it. So it's better to say what you said now in second attempt. Okay, Dr. Abdul Razak raised hand. Yes, please.
Before that, can I ask a question?
Yes, please.
So in HDU question,
yes,
my response was that I will start resuscitation and see the response, and then will let you know that if what I think about that, how patient is responding, and then we can, if needed, can shift to the HDU. Is that what are your comments? Because I couldn't understand the comments of Mr. Abbas, and thank you very much. He has told me about the catheter and things, but I couldn't understand exactly
basically
what should be the ideal response.
Yes, you should read the disease notes, because there your answers should be structured, and he has given explanation and answers in that structure, which can clear your concepts and give you the idea how you should put up or you bring about the answers. Because here HDU question is that, does he require high dependency unit transfer. Does he require, okay, do you want to transfer the patient? These are the few questions like they want you to make it clear. And then if HQ is full, how are you going to, or who are you going to speak to? So then you'll say you'll talk to the bed manager, and until then you'll resuscitate and manage the patient yourself. Right. Yeah, Dr. Abdul Razak wanted to say something.
Yes.
Oh, sorry, Abdul Aziz. I'm not sure who raised the hand.
Yes. Thank you very much, Dr. Shoaib, for the station. I just want to make some few comments. A lot have been said, so I don't want to repeat most things. I'll just start from the 8DU. When you were asked about the 8DU, you could say that the patient might require 8DU, but you're still resuscitating and hoping that if the patient doesn't respond, the patient will definitely require 8DU, and you will start talking to the bed manager to start making space available for the patient. Then, pending that time, you want to rearrange, you want to move the patient close to where the nurses are. But depending on how the ward is arranged, sometimes the patient might be far away from the nurses. So you want to ensure that the patient is close to where the nurses are, and there is frequent monitoring of the patient. Then what I also noticed when you were presenting is you were saying more of I will. I think when you spoke to the consultant, in fact, at the point in time you said the consultant is not the one on call, that is somebody else that was on call. You're actually talking to the consultant that is on call. So what you should tell the consultant is the patient is a 69-year-old who was operated yesterday, and tell the patient tell the consultant what you have done for the patient. Like, I've seen this patient, I've reviewed the patient, I've seen the urine output. This was urine output in the last 8 hours. I've examined the abdomen, it was soft, the bladder was empty, that tells the consultant that the catheter is not blocked. You need to tell the consultant what you have done, and then what you are planning to do and what you think you can do. So, when you were talking, I noticed that you were just saying you will do this, you will do this. You didn't really tell the consultant what you have done. So that's what I just want us to clear when you're communicating, because when you call a consultant, he wants to know what have you done for the patient, not just to tell me the history and tell me what you will do. Thank you.
Thank you very much. I would say humbly, so when I am calling my consultant, so correct me, Miss Amreen, if I'm wrong. So I can speak only things which are written on my paper, yes, which says, if it says abdomen is soft, non-tender, then I can say abdomen is soft, because in theory, I have papers in my hand, and I have to follow only what is written in the papers. I can't say if I didn't do anything. Like, for example, if I didn't check the catheter, because if there are no details about the catheter or no details about the head and neck examination, I can't speak I have done this, because all I can speak is whatever is given in the notes. So
yeah, we're saying the same thing really. From what was given, you could say that you've examined the abdomen. They didn't say who examined the abdomen. They told you abdomen was soft, meaning that you have checked abdomen was soft. So I've seen the abdomen was soft. Urine output is this. You understand? When you say you have examined the abdomen and it's soft, it doesn't mean that you have not done that.
Yeah.
You won't go away from what is on the candidate instruction. But what is on candidate instruction are things that you have done or you have seen in the noting, like urine output chart. Of course, you'll see that in the charts. But examination is expected that you should have done the examination, not call the consultant and tell the consultant that the examination was what you saw in the note. You understand? I don't know what I'm trying to say. It's just about the way you organize it. And also, before I forget, when they were talking about the causes of bleeding for this patient had liver biopsy, which could also be a pointer to bleeding, because the liver is very vascular. So when the consultant was asking, what do you want to do? You also want to do an ultrasound, because this patient HB was from 12 to 10 and has had 2 pints of blood So you don't expect the hypotension or the hemoglobin to still remain low. So there's something, probably patient is bleeding. Like Madam also said, it may also be a secondary hemorrhage. So, thank you.
Okay, thanks. Thank you very much.
Thank you. Yes, okay. Yes, so has it been clear to you?
Yeah.
Yeah, good. Thank you.